Good evening, everyone. Welcome to today's radiology webinar. My name is Jemima Mead. I'm Head of Marketing at VET.CT. Before I introduce our fantastic speaker, Manuel, I'm just going to take a moment or two to tell you a little bit about VET.CT and how our services can help you, your teams, and obviously your patients. So if you don't already know, VET.CT is a global company made up of over 200 specialists, and we are here to help you, whether in first opinion practice, university, specialty hospital, or another clinical setting. The service we're most well known for is our radiology service, where our radiologists provide expert interpretations on a range of imaging modalities, whether that's X-ray, all the way through to CT, MR, fluoroscopy, nuclear medicine, and across the full spectrum of species. What really sets us apart is the quality of our reports our exceptional radiologists provide. Not only will they annotate images so that you see the areas of concern that they see, we also ensure that the reports you receive contain clinically relevant differentials and comments. And all of our reports are backed by our unique clinical warranty so that you can trust the information in them and proceed with the next steps for your patient. Not only that, we also have an incredible support team who are all clinically trained and are available for you 24/7. You can ask for help and support at any time, and you can also communicate directly with our team of radiologists, so in case you have any questions on your case. We also have another service where we have about 50 specialists across a range of 13 different specialties, neurology, oncology, and such, that can also provide advice and input onto your case beyond radiology. Next slide, please, Manuel. If you haven't seen a VET.CT radiology report and you want to find out and see for yourself what our reports look like and how they can help, simply scan that QR code. And if you do like it and are interested, you can arrange a completely free, no obligation discovery call with any of our sales team. Simply email sales@vetct.com and someone will be in contact and you can have a call to find out a bit more. Right, webinar time. Tiny bit of housekeeping. It's being recorded, so if you do need to drop out or you miss anything or want to watch it back, you'll get emailed the link to the webinar in a day or two, and you can also share the recording with colleagues to help them. The talk will be about 30 minutes long or so, and then we'll have about 15 minutes for question and answers. And if you look at the bottom of your screen, there's a little box that says Q&A. Any question that comes up for you, either during the talk or the end, if you pop it in there, I'll collate them all and I'll ask them to Manuel at the end. Right, last slide, please. So that's it from me. I will be quiet and hand over to Manuel Pinilla. He's one of our senior radiologists and the senior director of Teleradiology at VET.CT. And tonight he's going to give you a really great talk around CT concepts in image acquisition and quality. Welcome, Manuel.
Thank you very much, Maima, and thank you everyone for being here at this time of the day. I don't know where people are connecting from, but I suspect quite a few will be connecting from the UK or Europe, so it's a bit late on the day. Now, it's a topic I'm quite excited about. I wanted to start to prepare kind of the content, and I ended at it, I think, quite a lot, and I get quite excited about it, and I start to speak really, really fast. So I apologize if that's the case. You can just send a comment there and ask them to let me know that I'm going too fast. Now, we did a similar talk a few years ago, and it was requested by some of our clients that we prepare something a little bit more in depth, and this is going to be it. So instead of one single recording, this is going to be 8 webinars. Are going to be split in 4 theoretical webinars. I will be doing most of those. And then there are going to be 4 practical case-based sessions that are used to reinforce some of the contents from the theory, but also to cover some others that we are going to exclude from the theoretical webinars, such as CT indications or something that is absolutely crucial for you to know when to do the CTs in that decision-making process. Now, this is what I would like to cover, and I know it's a lot, in the next 4 webinars. The first one today is going to be mostly this part, concepts of CT image quality. The idea, and I think the main goal, is this first and this last part of the program, and is that whether you've just started with CT, you are thinking about it, or you are experienced, it doesn't matter whether you are just acquiring them and not interpreting them, or the other way around. The very first part where we are confronted with a CT is that we are able to open it up and look at it objectively, identify whether the image quality is good or not, do that objectively, and then decide whether we need to repeat the study, we need to do additional sequences, we need to maybe change how we do our protocols and things like that. So that's the main goal, that you can by yourselves evaluate the quality of your studies. If we can get to, I will do a very brief overview of the actual CT imaging process, the different stages, which sometimes we kind of confuse, particularly acquisition and processing. So I will explain a little bit the differences. And then I don't think how far we will go, but we will jump into CT protocols, giving you some ideas as to how to set them up, how to prepare the system, the patient, positioning, and things like this. Most of this will be on webinar 2, but there is one part that is a lot of content. It's something that I know people struggle. It is a challenging one, and it's the use of contrast media. So we have decided we are going to do a whole webinar about it. It's going to be the third webinar, which Andrew Holloway will do for us. It's going to be a very exciting one. So if you have questions about that, hold them back because he will be the one to answer them. And the last part, we will probably just review some studies together. I'll give you some clues as to how to organize yourselves when you are viewing CT studies, because it can be quite daunting and complex. And more than to do so for actual interpretation, we are going to focus on quality. How do you open a CT study and conclude it is good, it is not good, or what it is I need to change on it? Now, very quick few disclaimers. First of all, VET.CT does not have any affiliation with any scanner manufacturer or retailer or with any company that installs or maintains them. Also, we're going to be talking about CT, and I wanted to clarify that there are different types of it. And whenever I say CT or any of the following speakers, we are talking about conventional CT systems, also known as MD-CT, multi-detector CT, or so on. I think most people will know which type of CT scanner they have. If you don't, generally multi-detector scanners are from brands that you may know from something else because they do photo cameras, they do jet engines, televisions, things like that. So things like GE, Siemens, Toshiba, which is now Canon, Hitachi. There are some smaller manufacturers as well that still do them. So then generally, if that resonates with you, that is a multi-detector scanner. If you are not sure, if you've heard, our system has, 32 slices or something like that. If there is someone telling you how many slices they have, that is also a multi-detector scanner. Now, the advice does not apply necessarily to cone beam CT. So if you have one of those, a lot of what we're going to be covering does not directly apply to your system, particularly when it comes to image quality standards and assessment. The images that they produce are very different to multi-detector CTs in many aspects. So not everything we say can be extrapolated. And just the last one is that we offer free and independent impartial advice if you are considering CT purchase or replacing your system by another. We will not be able to tell you which system you should buy, but we can give you some pointers as to what to think when you are making the decision, things not to overlook at that time, and so on. So image quality concepts. Today is the most theoretical of all of the lectures. We're going to go a little bit onto the physics of the image itself. And I know this can be a little bit boring, so I'm going to be making lots of analogies with photography because I think we all carry a photographic camera nowadays in our pockets, in our phone. So that may potentially make it a little bit easier to understand or more familiar with you. Now, first concept is spatial resolution, pretty straightforward. Then we're going to move into image noise. It's relatively straightforward, but causes a bit more confusion, and is directly linked to contrast resolution. And when we speak today about contrast resolution, it does not have anything to do with contrast medium, with iodine or anything. It's about contrast within the image, how different things appear in your screen. And lastly, temporal resolution. Now, those two in the middle are really linked together, but overall, they are all going to interlink. Okay, and that is what I try to explain through examples towards the end, how there's going to be a lot of things to decide, a lot of compromises. So a spatial resolution, start with the first one, very, very straightforward, is the ability of an imaging system to differentiate two nearby small objects. So this is when we are looking for the smallest stuff, for anatomical detail. How well can we see those little things? Starting with this one, because it's probably where CT excels, is brilliant at it. It's inherently good at it. But even though it's good, there are still some requirements for it to give us the resolution. You need to acquire the images properly, and you need to process them properly. These are two different things that we do when we are doing a CT scan. They are separate things. So basically, your image has to be optimized. And beyond that, there are things you do not necessarily have control of, and is that the structure you are looking for must be different, significantly different to whatever is around it. It's like if you try to paint with a black marker on a black wall, you are not going to see it. It's a little bit the same. You need to have that contrast. Just some examples of where spatial resolution can be very easily observed is, for example, when you look at a bone, we've got very sharp periosteal margins because it is surrounded by soft tissue, and soft tissue and bone are very different. Or, for example, here we have the subchondral bone, and then we can see that it's different to the trabecular bone because we've got cancellous bone here. It's got little pockets of fat. So again, we've got that difference in density. Or, for example, we see the endosteal margins because we've got fat in contact with bone, so drastically different density. So in those cases, CT is going to provide us that detail. Another good example is the nose. Why do we see the turbinates so well? Well, because they are surrounded by air, and air and the turbinates, which is a mucosa, well, it's bone with a little bit of mucosa around, are very different to air. Or the same, for example, for even smaller stuff, like if we look at this tooth, we can see it as a separate thing from this bone, and in between we've got a little thin layer of soft tissue, which is the periodontal ligament. So again, we've got bone, periodontal ligament, which is a soft tissue, and then a tooth, which is something really, really hard. And the last example to show this is with lung vessels. This is a pre-contrast CT. I know it looks a bit bizarre. Maybe you are not saying, oh, what does that look really good? We see the vessel so well. This is a thick slab, so it's a maximal intensity projection. We've made it like a little bit of a volume to it. And you can see that we can follow the vessels up to a point where they are probably like 1/3 of a millimeter. The very periphery of the lung, you can see it's got no vessels. Well, it does have vessels. What is happening that we have exceeded the spatial resolution capacity of the system. So at some point, we no longer see the little vessels. But you can see that we can see very small stuff, provided is, for example, fluid around with air around it. Now, a concept that we overlook is that we assess spatial resolution. People do this on the transverse plane, and this image is fantastic, but we've got a two-plane. This is a 2D image. We've got one axis and the other. And the spatial resolution can be brilliant here, but once we start to reconstruct things and we look at images across time, because remember, when you start a scanner, a CT scan, it does not take a snapshot in time. It scans over time. It's going to take some time. So when we put all of those images together and we start to change the plane, we still want to be able to see this fantastic resolution. We see all the turbinates. This bone looks very, very smooth. And this is something that when we assess spatial resolution, we should not forget is resolution across the planes or along the the Z axis. Now, this is what could be exactly with the same beautiful transverse images. You could end with this kind of step ladder, losing resolution and things like this. So this we will review it towards the last of the lectures, and we will touch again on this concept. Now, what happens if you want to see something that is very small, but is surrounded by something that is the same density? Well, you cannot see it unless if you can put contrast. And that is what contrast does. So in this case, for example, we've got the portal vessels. We can see them beautifully. It looks a little bit like the lungs. And here we've got the hepatic veins parallel to them, and we can follow them into the periphery, again, into submillimetric sizes. But the only reason why we can achieve this is because we have artifactually or artificially change the density of one of the structures. All right, so that's for a spatial resolution. Again, pretty simple concept. Image noise, I think is also simple, but we tend, at least maybe, I don't know if it's a language thing, when we think of noise, we think of sound, but it is the same. You're trying to listen to a movie and someone is talking near you. There is some kind of signal your ears is receiving that is blocking what you are trying to actually hear. With the images, is the same. The definition sounds a little bit difficult to maybe understand, but you will see with some examples that it is not so. It's basically random variations when it comes to images, either the brightness or the color, regarding the information that it is within an image. And I'm gonna basically tell you now, it just looks like graininess. So an image that is a bit mottled, a little bit speckled, and not very smooth. And you will all be familiar when you take photos. Image on the left is a dark room, believe it or not. Phones are amazingly good quality nowadays. The one on the right is with the light on and with a flash. And yeah, we recognize a guitar, and like that, maybe they do not look that different. But if we start to look into the detail, so we are looking at the sticker inside the guitar, you can see that this image looks really, really granular, and we've lost a lot of detail. We cannot read this. This looks like a line of some kind, and here we can see the sign by blah, blah, blah. So you can see kind of this difference and how this noise affects a photographic image. On the CT, it's exactly the same. I have selected an image that has a filter that is actually designed to enhance noise because we want to see sharp margins. So this image technically is to look at bone, but I'm using it to look at the brain. And then we can see all of this noise, which makes it almost painful to look at. We still have some soft tissue resolution. We can see a little bit of the ventricles. We can just about see that the brain is a bit less dense than muscle, but you can agree that this image is pretty terrible. It's way too noisy. What is causing this is exactly the same. Taking photos and taking CTs, they are not all that different. We are used detecting photons. Those are light photons for photographs. In our case, for CT are X-rays. But the idea is the same. If we do not have enough of them, then the system cannot really reproduce whatever structure it is in detail. It starts to make things up, or just there is some error within the system. So as a consequence, the image is going to suffer significantly. The biggest consequence is going to be a massive drop in contrast resolution, in the ability to see the contrast between the structures, but the spatial resolution also drops. You saw in that guitar, we could not read things because we were unable to resolve those letters. Now, what can we do to reduce it? So it is lack of photons. You can guess what we need is more photons. You need to increase the amount of signal. Now, on green is the analogy with the photographs. In the CT, we do not turn on the lights or use a flash, but we increase the MA. We need more photons. What we are doing with CT, basically, we are throwing photons across a patient, and we are waiting for them on the other side. And then we see how many of them reach, how many have been lost on the battle going through a bone or something like this. If you do not send enough photons, then the system is going to fail. It's going to have to start to make things up. And that's why the pixels start to vary a lot on their value. So on the CT, you would need to increase the MA, which is sending more photons. And this is exactly the same as we've done here by turning the lights on. The problem is with the CT, when you do this, you are using more radiation, and that is potentially bad for the patient. That is potentially bad for your system. It's bad for lots of things, even for the environment. CTs are very power-hungry machines, okay? So that is the kind of the drawdown, because it's not a matter of saying, well, you send as many as the system can, okay? You have to find that balance. The other way to get more photons is make it last longer, scan for a longer time your patient. And that is a little bit like taking a longer exposure with your photograph camera or whatever. This is how you manage to, for example, see stars. You need to do a very long exposure. And even if there is little light, your camera still captures it. But even though you get beautiful photos, you can, for example, see here, there is that line there. I don't know if it's how do you call them, a shooting star, or whether it's a satellite or something. It's something that is moving on the sky. And we no longer see it as a little dot, which is where we would like to see. There is blur and it's turned into a line. So if you do too long CT scans, then there is going to be worse temporal resolution. Motion is going to be more of an issue if the scanner takes longer. So you are going to have to find that balance again. And lastly, the other option for CT is to make thicker slices, because within that slice, now there is more information for us to recreate an image. And this is why phones nowadays have lots of cameras, or at least one of the reasons is that you take multiple photos and you combine them. With CT, we do this. We take multiple consecutive slices or a larger chunk of patient. Basically, we combine all of that information, but we end with a thicker slice, and that means we will get worse spatial resolution. So you start to see that you cannot win every battle when it comes to quality, all right? And every single thing that you can do to improve something is going to have some kind of negative impact. There are other ways, but this is the main ones. Unfortunately, scanners do not have like a knob that you turn for more noise, less noise kind of thing. Okay, so it's a bit of a juggling art how to reach these. Also, not all scanners will allow you to, for example, select an MA and then a time. Some of them will have MAS or effective MAS, and kind of this becomes a little bit harder depending on one system versus the other. Now, we can send more photons, but we can also filter the image. This is not me, by the way. It's just a random photo from one of these filters that you can get on your phones with different apps. And you can see that the image has been made smoother. So some of the, I don't know if we can call them imperfections. Sorry, I jumped one ahead. Like pores, little freckles, wrinkles, stuff like that, they disappear in the image. We can do exactly the same thing. In fact, we do it every single time we do a scan. Noise is in every single image, and then we need to decide how much of it we want to see, how much of it we want to smooth out. Considering that it's just you make it too smooth, then you will also make some things disappear. But this is basically the exact same image, They are displayed with the same contrast and brightness, so the same window settings. But this image on the left is being designed or created to highlight differences in attenuation so that we can see margins. We would not use this image for looking at the brain, which is what we are trying to do here, but we do the same image, but we apply those filters. And now suddenly we can start to see loads more stuff. As I said before, we can clearly see that muscle is more dense than brain. We can see the lateral ventricles, a bit of the third ventricle, and you can even see if you look this, for example, blob here and blob here are a bit more dense than this. So these are the caudate nucleus, this is the white matter, corona radiata, and so on. So you can start to get a lot of detail, but for that we need to make sure there is not too much noise, smooth out or filter out some of that remaining noise, and ultimately make sure that you use the adequate viewing parameters, that you display the image with a window width and window level, which we will explain in webinar 4, that does not kind of make the image all granular and horrible. In contrast resolution, it goes along noise. Contrast resolution technically is the ability to distinguish between differences in attenuation. So we have structures close together or one within the other that they are slightly different density. And a good contrast resolution should allow us to identify them as separate structures. And these are just some random examples of good quality CTs. Here we are at the heart and we've got blood and we've got the muscle. And if your CT scan is properly done or optimized for contrast resolution, you should be able to see those differences. And you should be able to, for example, identify blood clots or something like that in pre-contrast series. The same here, we've got the hepatic veins. Blood is less dense than a liver. And we've got the gallbladder, for example, which is also less dense than a liver. So if your study is properly optimized, these are some examples of images where you should be getting. Again, towards the end of the webinar series, I will be just putting up cases and telling you how to go step by step and be able to check that all types of different resolutions are satisfactory for the indications of the scan. Again, contrast resolution is critical for soft tissues. This is probably where we fail when we are doing CT studies, is that, yeah, spatial resolution looks great. Yeah, your teeth, the nose, the bones, you can always see those, but can you actually see gray and white matter in the brain? Can you see, for example, the hepatic veins inside the liver? That is what is going to be critical for most pathologies. Now, how do we improve it? Again, we need to reduce noise. Noise and contrast resolution go pretty much against each other. If you decrease noise, your ability to see the soft tissues increases. So what I said for noise is just the opposite for contrast resolution. You want to make a better soft tissue image. You need more photons. You need to use the correct filters and so on. Temporal resolution. This is the ability to resolve moving objects. As we discussed already, we're going to go quickly through this. It is very important because it affects the image significantly. It creates ghosting, blurring of images, and so on. It limits overall the diagnostic interpretation of the studies. It's very important that we try to minimize the impact of motion. This is just an example of a thorax where there is a bit of respiration. It happens very often. We work with live patients generally, so it's pretty understandable. But you can see how we've got like two surfaces of the lung here. The same here. We have like two bronchial walls parallel to each other. The same with this bronchus. There's kind of this ghosting and anatomical distortion in the image. And this is where it highlights the limitations. This is the same patient on a sagittal reconstruction. And look at the diaphragm. We've got inspiration, expiration, inspiration, expiration. If the lung is moving while we are scanning and it's moving parallel, like at the same in the same axis as the scanner itself, it means that some parts of the lung we're going to scan them probably twice, and others we may miss them altogether. So if you want to know whether there are metastases in this dog, I say, well, at least in the part you have scanned, there are none, but it could be that we have missed them altogether. So the limitations are real, and you have to keep them in mind. How we reduce it? Pretty straightforward. Sedation and anesthesia are going to be needed for all CT scans. There will be very few exceptions, and that we can discuss later if we have time during the questions and answers. Not only that, but inducing apnea is often very, very useful. And then using some restraints like Velcros, wedges, tape, ropes, whatever it is. The other one is make faster scanners. There is, however, an issue is that some people buy a massive, like 128 slide CT because they've told them you can do a full dog in 6 seconds. Yes, you can, but if you go too fast, it means there are fewer photons going through the patient, which means higher noise, which means, yes, you will have scanned the entire patient, but you have no contrast resolution, so you cannot see anything. So that is the kind of the decision to make. How fast do you want to go? How much image quality you want to compromise? The other one is to position the patient so that you reduce motion, not of the patient, but of the actual body area of interest. And this is a good example of that. The patient is on its side, and look at these ribs. So we've got the table here, one rib there and one rib there. I'm going to zoom on them. A bit pixely. A photo is from Dr. Tobias Schwartz from one of his lectures. I found it. I thought it was useful to show here. But this rib, we can see one of them. And here, this rib, you can see that there is two of them. And what is happening when the dog breathes, this thoracic wall that is on top is moving up and down. But the one that is at the bottom is pinned against the table and is not going anywhere. So long story short, even if the patient has some motion because he's alive, try to keep the things that are of interest right against the table. We will go into details of positioning maybe later, maybe in the next session, and we will show this with examples again. Then when you start to scan, in which direction you think. So there are lots of things to consider. If we look, for example, at the thorax in this dog, this is a scanogram. This is the images the CT scanner does to allow you to plan where you want to start, where you want to finish, how much area you want reconstructed. And if this dog is going to be in apnea or is breathing very slowly, you could check the same way like with radiographs and say, okay, oh, it's breath now, I start the scanner. And do it in between two breaths, for example, but you want to maximize the time of apnea that you have and focus on the areas that move most. So in a thorax, what moves most is the caudal half because it is the diaphragm. If the dog breathes when you are cranial to the heart, it doesn't really change that much. So on top of choosing where you start or where you finish, you must choose correctly in which direction you want your scanner to go. You want to go away from the diaphragm, where the moving parts are. And CT gating, there's a lot more complex ways, which generally we do not use in veterinary for different reasons. So these are the main concepts, so particularly the three resolutions, spatial, contrast, and temporal. And you can see that they are all kind of interlinked, but not really linked like in a chain as I've done. If you increase the spatial resolution, it's not going to pull everything up and increase all of the other resolution. It's more like a tug of war, okay? There is an uncontrollable truth, and is that it is not possible to fully optimize contrast resolution, spatial resolution, and temporal resolution simultaneously. You need to make choices. You need to decide what it is important for you for that particular case, for that particular indication. So there are four main concepts, four ideas that I want you to keep in mind. I think it's four, maybe it's five, I don't remember. We will see. That's the first one, though. Understand the specific indications for the study. Why am I doing in this dog, I don't know, a limb? It's because you got a soft tissue mass. Am I looking at a joint disease or like an elbow or something like that? What is the exact indication? I know things are not always easy in practice, and the cat is not eating. You don't even know what's wrong with him. Is he painful somewhere? I don't know because I cannot touch it, and so on. But ideally, you want to start with the specific indications. It's going to help you make the decisions. It's going to help you optimize the study, and it's going to make sure that the diagnostic yield of the CT scan is maximized because the radiologist is also going to be able to answer your specific questions. Limit the study to the body areas that are necessary for the case. If you do not know in which joint, the dog is walking funny, I don't know if it's the carpus, the elbows, the shoulder, the pelvis, the stifle, the blah, blah. It's going to be impossible for you to optimize the study because you are going to overheat the scanner because you need to scan longer areas, which means, your MAS is going to have to drop and so on. So try to identify where the pathology is located. I know it's not always possible, or sometimes you will have multiple body areas that are of concern. You want to check this area, but also in case there are meds, I want to check somewhere else. But if you can try to keep it to the minimum that is properly relevant for the investigation, do so. Always produce multiple series. We will cover this in the webinar 2. Every time you fire the scanner is always at least two sets of two sets of images. Even if you only scan once, you will always process them twice. You want to optimize one of the series for a spatial resolution, the other one for contrast or soft tissues. And then you have to build a library of CT protocols, and you are never going to have the protocols that work for every single case. You are going to need to gain some knowledge or some insights as to how do you adapt them, because you're going to use those protocols kind of as templates to start with, but depending on the specific indications, you may need to tweak them a little bit. Now, it's a lot of things, just for little things drop there, but there's a lot of meat on them to, lots of things to kind of decide. I think I have 5 minutes, and I'm not going to be able to cover the next one. I'm just going to jump Slide 24. Let's go to this one. I'm going to start talking about patient preparations. And we're going to go into the details of protocols, which is what I wanted to do on the next two webinars more in detail. How do you set up these protocols? But the first stage is patient preparation. Well, the first stage is probably decision making. Do I do a CT? Yes, no, and on which parts? But that we're going to leave it to you, to the clinicians, or maybe you don't have a say. Maybe you are, I don't know, you are a technician or a vet that runs a scanner or a veterinary nurse, and you are asked to do the head or whatever, right? So we're going to leave that aside, and we're going to start with some of the basic tips for patient preparation. Some of these maybe Andrew Holloway will remind you of them later. We want a patient that doesn't move. This means vast majority of time is anesthesia or deep sedation. If the patient is unconscious or something like that, obviously you don't need that. But if the patient is unstable, I know this is when the questions start, before you decide, is just make sure CT is really indicated at that moment in time. We get this all the time where they just put a cat in a box and they scan the box. I mean, you can do that, right? But the limitations make it so that is it worth spending that money at that time? Or maybe there's other things you can do to help that cat and not stress it by chucking it in a cage. Like, for example, I don't know, point of care ultrasound. I don't know, additional tests. Stabilize the patient first, and then go ahead and try to do it either anesthetized or sedated. I would always recommend you have an IV line in place. Mostly you will be doing that anyway if it's particularly anesthetized. We generally use the front limb, and if you are going to inject by hand, use a thick, big catheter. Okay, so this is a little bit for the contrast delivery thing, but also for patient safety is good practice. And then please do not do any procedures that really are not necessary for patient safety before you do the CT scan. If you suspect a nasal foreign body, you do a rhinoscopy, then just do not bother doing the CT right after, okay? As an example. Draining lesions, taking biopsies, doing endoscopies. Ideally, we want to see the patient before you've done any of those. If you have to do them before, then just leave it for a couple of days or something. But it is very important that we scan it first. Sometimes you may use the CT and say, oh, I need to drain that chest. I'll do it right away and then repeat it. That is fine. Or just do it before, again, if it's for patient safety, but otherwise just hold for a little longer. And then for the thorax, very specifically, if you are going to anesthetize the patient, do not leave it anesthetized for half an hour before you do it. And also do not put the patient on its side or on its back before you do the CT scan. Ideally, if you are going to have to do a CT scan and something else, my advice is just do the scan as you induce the patient. You induce it on the scan on the CT room, do the CT of the thorax, and then do whatever else, okay? Because otherwise the lung very quickly starts to collapse. Now, I think I've got time still, Jemima, I see you there, yeah? Okay, I'm gonna go 3-4 minutes to something that is gonna sound very simple. See, 4 simple principles, and they are simple, but they are almost unachievable as well. It doesn't matter, you still have to understand these ones. I'm gonna explain you the basic things you need to consider to decide how you position a patient. I'm not talking about the patient, I'm talking about the specific body area. It's simple. First of all, the body area should be immobile. We've said that. Second one, it should be alone. Technically, ideally, when possible, the only thing inside the gantry, inside the ring of the scanner, it should be the body area that you are interested on. Obviously, we cannot cut pieces of the patient and put them in the scanner, which would be great. It would solve all of our issues. But you need to minimize whatever is going into the scanner. And we will see that as we set protocols for different body areas, how to achieve it whenever it's achievable. They have to be aligned and centered with the scanner. And for this, I've drawn a CT scanner. I'm very proud. We're seeing it sideways here and here from the front. And just as an example, we're going to put a bone. Try to make sure that it is not at a random angle. We want it to be aligned with the table. And that's what we call the y-axis. So it should be parallel to the table and going from one end of the table to the other. And lastly, make sure that the area of interest is in the center of the scanner. So in this case, we need to bring the table up a little bit and make sure it's centered with the lasers, okay? And the last one, we can always almost forget it. This is 3 simple principles because the last one is only mostly for the thorax and abdomen, where we want to scan things in a physiological position because otherwise things collapse or move around. It's where those areas where gravity is a bit of an issue. Now, I'm going to just do 1, maybe 2 body areas just as a random example. Can we achieve all of those? Remember, they go in that order for a reason. You have to, if you have to sacrifice in one of them, start from the bottom. You need to achieve one is the first one. Can we get ahead immobile without any motion? Yeah, sedate or anesthetize the patient, check it in the scanner. They sit really nicely, immobile, Perfect. So we can definitely achieve that. Next one, make sure there's only the head alone in there. And we already see this is not going to work because we've got both elbows now, which are at the level of the roughly the middle ears, the inner ears, whereas the petrostemporal bone, we are going to get a lot of artifacts. Yes, it does impact the image. So people start to say, okay, well, let's just put them a little bit away. The radiologists won't see them that way. But we still see them in the image, and particularly now we have the catheter, for example. When you inject contrast and leave a syringe half full of contrast in there, you're going to have massive artifacts across that brain. So what do we do with the front legs? Put them back, a little bit like, I don't know how to call it, like a seal or something like that. So yeah, it's not maybe a best choice of color because we don't see them, but they are pointing down. Now the neck and the head can go in the scanner by themselves without any other structures, and this means less artifacts. So pull the limbs backwards. Now, align it with the scanner. If you do it in this position in external, the mandibles will normally hold the head pretty straight and pretty much aligned with the table. So it's easy to achieve. And physiological position is not really important. I think it's easier to keep it straight if you do it on the stern rather than the back, but you technically can do both because gravity does not affect the head. So you can see that in that case, for example, is very, very easy to do. I think I'm going to leave this one. I think I've been just over 30 minutes. Jemima, should I finish this one? We jump into questions. Is that a go ahead or is that a stop talking?
It's a go ahead, Manuel. It's fine.
All right, cool. So I just wanted to go into something that is completely different position. And in this case, I chose the thoracolumbar spine, which we often receive in a suboptimal position. So let's start with our order of things. Remember them all. So the first one, immobile. Can we keep the thoracolumbar spine completely immobile? Well, first stage, sedate. Deep sedation normally may be enough, or ideally anesthetize the patient. Check. But then there's still something that is really important. The patient cannot be in external. It has to be on its back. This is something that has sent docs to theater. Lots of misdiagnoses have been made. If you put the patient in external position, when it breathes, the spine jumps up and down. In this case, for example, it's done that right at the level of the discs, and it looks like it's got a couple of spinal subluxations. If it does it in the middle of the vertebra, sometimes it looks like there's a fracture. Sometimes it looks like a disc. Sometimes it's not as obvious as you think that it is an actual artifact. So you have to be very, very careful. Patient goes on its back. Look at this myelogram where you've got all of this. In this case, it's very obvious. And you can actually check the respiratory rate. So 1, 2, 3, 4, 5, 6 breaths, his 6 breaths. If he's a minute, well, it's one breath every 10 seconds, for example. So you really do not want to see respiratory rates on a spinal disc, okay? This can look like leakage, like a disc, like something like that, okay? Now, can we keep the spine alone? Yeah, no, we cannot remove the thorax and the abdomen, so those are going to have to go. But for example, do not leave the legs like in a frog-leg position, because then when you scan the lumbosacral area, you're going to have both stifles across the same image, and that causes massive strikes, massive beam hardening artifacts. So pull the hind limbs backwards. So you see, if you work through the steps that I mentioned, you get to kind of the optimal positioning for every area. Align. If you want the spine to be as straight as you can, put it on its back, which kind of helps us as well with immobile. In a physiological position, I don't think so. You cannot do a kind of a weight-bearing standing dog for the spine. It would be really interesting, particularly for limbs, but we don't. But it's the last of the four, so we can kind of exclude that. So how do we do the spines, for example? Put them on their back, pull the hind limbs. But you can see that you can figure all of this out just by following 3 kind of relatively basic rules. I'm gonna jump directly onto the any questions part. Jemima, I think we've just kind of covered most of what I wanted to. So I don't know if anyone has asked something that I can try to answer.
Yeah, we've had quite a few, Manuel, thank you. And we've also had quite a lot of comments about how you've taken a really complex topic and made it really easy to understand.
Okay, fair enough.
Lots of comments around how
Thank you very much. Yeah.
Thank you. The first question is around assessing image quality. So it's around, is there a method or a tool for being able to assess the quality of CT scans?
Okay, there are things you can measure technically, but we don't. Most of the assessment is purely subjective by evaluating the images themselves, and that is what we will cover on the webinar 4. I think I'm going to do it more with practical examples. But technically, you can measure things. Like, for example, noise, you can draw a region of interest in a part of the study that let's say in the air of the room, and it should give you a perfect value. Air is 1,000 Hounsfield units, for example. But if you do that, you will see that it gives you an average. It tells you it's minus 985, and the pixels within that region have a standard deviation of whatever. So you could technically measure some of these things, but we limit it to kind of visual inspection. Okay, you do not need to measure anything. There are no particular tools out there that I know. I wonder why there are none, to be honest. AI should do of things like this a very easy job. Should be in the scanner, really. Your scanner should be telling you at the end of the day, you've done a terrible job, repeat it, or something like that. Or just do part of the job for you, or helping you, basically. But at the moment, I don't think there are any particular tools.
Okay. You said about a terrible job, and that's interesting because there was another question around the quality, if the quality is poor. So it says, if the quality of the CT I've taken is poor, will you still report it?
Okay. Short answer is yes, because I think if we didn't, a large percentage of what we do, we would not, we would be sitting idle. So unfortunately, image quality is often suboptimal. When it comes to CT, there is a very interesting thing to assess, and is the fact that the images that we get are determined by what you did when you acquired the study, but also what you did afterwards. And what I mean is that sometimes we may have an image that is suboptimal, but you can solve the problem without repeating the scan. So for example, if you, I don't know, you send an elbow CT and there is no bone series, the radiologist technically should not report it because there are limitations that you can solve without rescanning the patient. So you go back to your scanner, produce the series that we need, and send it across. So in that case, we would not report it immediately, but we will ask the clinician to send us everything we need.
Okay.
If the error cannot be solved by reconstructing the image, I don't know, you position the patient in the wrong way, we will generally try to report it as much as we can because we know you need to repeat the study. We know the pain that that causes to you, to your patient, to your client, to everyone. But very often we will have to kind of include some sort of disclaimer or explain the limitations within the report. Like, you know, if you don't send me the full thorax, can I say there are no metastases? I may have to say something like, in the included part of the thorax, there are no metastases, if that makes sense.
Yeah, it does make sense. You mentioned there about post-processing, and there was a question here around, you talked around acquisition settings and processing settings. So the question is, if I make an error with my acquisition settings, can I compensate and correct with my processing settings?
Okay, so that's one of the slides that I jumped, and I've got it ready as 23. I've got it written because I knew I wouldn't be able to get to it. I will start the next webinar with this part.
Okay.
This here is what we do during image generation, and these two concepts and these two processes overlap quite a lot. There are certain the pure acquisition parameters, such as the kilovoltage of the system or how you position the patient. There is nothing you can do afterwards. But if you mess up the processing, like your slices are too thin, too thick, you generally can go back to the scanner and solve that. So I will explain what the difference is, how these processes overlap. But if it's a purely acquisition, so those parameters that some of the parameters that you put in the scanner, there is no way to solve it. Okay. If it is a reconstruction parameter, then yes. And I think this is the problem, is that it is not always clear for people what is an acquisition parameter, what's a processing parameter, because everything happens in the same system, and very often you put the settings for both things before you scan the patient. But they are technically different, and they can be done at a different time and solve. So yeah, everything that is processing, you can just go back, provided you still have the raw data in your scanner, and you can kind of solve it.
Great. So whoever asked that question, please come back next time. And
yeah, yeah, definitely for the next one, we'll have it. I'm gonna jump to the Q&A. There we go.
Amazing. The last one that's come through is around apnea. You mentioned apnea earlier. Have you got any practical tips on achieving apnea?
Okay. Yes, I do. I do like to. I tend to always scan patients in in expiratory apnea. So we let them basically exhale, and while they are not breathing in, we try to scan them. The other way to keep them steady would be to kind of to do a breath hold. So how do you achieve apnea? First of all, I want to say I'm not an anesthetist. I hope whatever I advise is not dangerous for the patient. I've done it many times. I've never had any issues. But I've also mostly worked with CT scans where the anesthesia equipment is outside of the CT room. So there's a hole in the wall, and then you can balloon the patient from the control room, which I know is fantastic, but most people don't have. So you will have to do a little bit of running in and out of the room, which is fine. Make sure you don't get exposed to radiation, that you are always outside of the room. And the way to achieve it, you hyperventilate the patient. So you give them a few breaths with the bag, making sure you do not, give too much pressure. Generally, you want to have a capnograph and, well, all the sort of monitoring for the anesthesia, and just drop the CO2. I don't dare giving you exact numbers as to how much. Generally, I drop it as little as you can for the patient to give you. Generally, 30 seconds should be more than enough if you are just doing kind of a thorax. At least that will give you the first, like the caudal part of the thorax, which is where motion affects that. So yeah, just hyperventilate the patient. Make sure the scanner is ready to fire. Someone should be driving the system, so you hyperventilate. And as soon as you get out of the room, you start it. Okay, you should generally be able to get 30, 45 seconds sometimes of time. Yeah.
Amazing. Thank you, Manuel. I'm just checking. I think that was the last of the questions it was. So I think I concludes, there's probably one more slide, if you don't mind.
Yep. Here we go.
Yeah, which is, you mentioned earlier that this is webinar 1 of 8 radiology ones that are coming up. So if you would like to register for any more of the webinars, please just scan the QR code and that will take you to our page where you can access all previous webinars that we've done across all of the different disciplines and sign up for the next radiology webinars. And equally, if you've been inspired by what Manuel said and want to see how we can help you in your practice, please do drop us a line at sales@VET.CT.com and someone of the team will get back to you. Thank you very much, Manuel. It's been brilliant.
Thank you very much. Bye.